Good afternoon. My name is Fran Cousins, and I'm a partner specialising in healthcare technology at Deloitte. You're very welcome to the second in our series of webinars looking at effective electronic patient record implementations. Today, we're going to focus on workflow design and content. It's fantastic to have so many of you join us, with representatives from over 12 countries and nearly 100 people. So thanks for making the time to join. We know that you'll have questions, and we would love you to ask those questions by entering them into the chat. We'll then access those questions throughout the process of the webinar. So as I mentioned, this is a series of 7 webinars that cover the whole life cycle of an EPR implementation. Our focus is on effective partnerships, those necessary to succeed in EPR implementations. We want to highlight the common pitfalls that might be faced and areas where support can be provided. We'll be sharing key strategies, those necessary for healthcare practice transformation, because it's very much our belief that electronic patient records can be a real vehicle for transforming your organisation, and that specifically clinical workflow design and its associated content is one of the primary drivers for that really exciting change that can be leveraged from your EPR implementation. So the team joining you today are experienced practitioners. I have 20 years experience in the NHS implementing large-scale digital programs. I'll now hand to my colleague Mark, who will introduce himself.
Great, good afternoon, Mark Perlman. I'm a partner in the US firm, and I also serve as a global digital care leader for Deloitte. Thank you for joining us.
Good afternoon, I'm Denise Mancuso. I am a nurse by background, and I also specialize in leading and supporting clients through large EMR implementations.
I'm Mark Snyder. I'm a physician in the US practice, and I've worked with a number of large healthcare organizations on their EPR implementations and optimizations.
Hi everyone, I'm Cindy Stumeyer, and just like Denise, I am a nurse by background, and I specialize in working with clients on their EPR implementations.
Thank you. And it's my great pleasure to bring such an experienced clinical team who really understand the detail of how workflow can drive practice change and promote best practice. I'll now hand to my colleague Mark to talk through the agenda for today.
Great, thank you very much, Fran. Just like in any good clinical workflow or process type of discussion, we decided we would break our agenda into a workflow for everybody. First, Denise will talk about some of workflows in terms of what they are, how they actually help you create benefit to your organization. How do you look to really reduce the clinical variability and help you understand some of the basics of really being effective within your workflow development process? Cindy will get more detailed in terms of the strategy, the governance, how we get the right people to the table in order to really make things stick, because what we're looking to do is transform an organization, as we had indicated earlier, and as such, buy-in, getting people on the ultimate software, people need to be buying into the process. And then finally, Dr. Snyder will take the time to talk about achieving goals, what adoption is all about, and really how, once you're getting transforming, how we get everybody on board, truly operating as one organization with the EPR as a catalyst to help go there. And then finally, we'll get into a question and answer period. And as we had indicated earlier, feel free to type something into the chat box if there's a question. And we'll try to get to all the questions we can. And then Fran and I'll be on to talk about a few other resources. So with that, it's my honor to introduce Denise Mancuso. Denise?
Great. Thanks, Mark. So before we dive into our discussion, I'd hate to go too far and not set the right context around what workflows are. So workflows are our guide and our recipe for how we are designing our EPR. We're going to spend the first time of this conversation looking at what a good workflow looks like, how they're used throughout an EPR implementation, and why they are important. So workflows are the foundation for a successful EPR implementation. They're not optional, they are essential. Workflows establish the standardized pattern and the process flow for how clinicians and the rest of your staff will utilize this very powerful tool, your EPR. Recipes can be the recipe for how you transform how you are delivering care and create successful patient experiences. So a workflow is designed as a series of steps which may be sequential, they may be performed in parallel, they may be performed by one staff member or by many staff members, and they're frequently performed with a goal of accomplishing a particular task. Workflows represent how the work actually gets done, which may or may not align with the protocols up until this point you've established to do that work. It's really uncovering how the work truly gets done. Once you sort out your workflows, of course, you're going to go back and make sure that your policies, your protocols, and your procedures all align to these workflows. So what could be a task that you would do workflows around? It could be around how you are making appointments, and it would include the rules and priorities of how different appointments for different providers are handled. It could be as simple as, how do you room the patient? How do you order tests and then review results? So all of these workflows, they do come with an EPR vendor. Your EPR vendor will bring some very basic system-focused workflows. They are workflows that are very specific to their software. But what we're talking about today is more robust workflows. These are workflows on how you will operationally and technically, by role, deliver and hook together all of these different processes to create that whole experience. Also, the vendor workflows do not account for things like other third parties that you may be using to support your system. So a third party could be like your blood management system, if it's not coming from your EPR, or your dietary system. So you've also got to map out and plan for how do you do those handoffs and connections with third parties that are outside of this, outside of your EPR. All that said, long story, the vendor software workflows are a good starting point, but they are not complete to do your EPR implementation. So workflows impact all areas of your organization. They're not just clinical. So it's all for your ambulatory outpatient setting, inpatient, all of your revenue cycle, how you do your scheduling, your registration, your processing of claims, and as I mentioned, all the many, many third parties that will also interact with your EPR system. So let's take a look at what the anatomy of a workflow may look like. The most common tool that we see used to document workflows is the Microsoft Visio application. Now, as we get further into this discussion, we're going to talk about some other tools and specifically some tools that Deloitte has to help with these workflows. But from this example, this is a Visio. Let's just orient to some of the things that I would say are the must-haves. So first off, we're all going to need to have a basic template so that all the workflows you're creating for your workflow library have a standard look and feel. Then we want to make sure that we're naming them so people can actually find and reference these workflows. We want to look along the left-hand corner. I think it would be the left hand when we're looking at it, those gray boxes, those are the roles. So we want to make sure that we have swim lanes and we have standardized roles for who's doing the work, and that across the organization, we're not calling a nurse by 3 or 4 different names. It is the nurse, it is the provider, or whatever you decide, but standardized role-based names. We want to make sure that we're all understanding how to use the different icons within the workflow. Like the triangle, it denotes a point of decision. We want to put enough example in there of, I shouldn't say example, but enough context to show if we've made a decision that impacts the organization and impacts why we're doing the workflow in a particular way, let's call that out. Let's also call out if there's something on the workflow that's going to be a major change from the way folks are doing it today. And that could happen because you could have several different organizations all under the same umbrella of the same health system, but they do things differently. We want to get to a standardized way of doing things. So for some folks, that could be a big change. And a big change would mean a big point to focus on for training. So I think maybe to, excuse me, to help people really understand, because this is kind of just a generic example. Fran has an example from her past experience in implementing where all of these things come together and why this makes a difference to do it this way.
Thank you, Denise. So I just want to tell you a story of when we implemented a large, well-known electronic patient record. And about 6 weeks after go live, I went to sit with one of the medical secretaries and to talk to her about how her role had changed. And what this did was really bring home to me why it's really important at this early stage in your EPR implementation to think about workflows, because the change in that individual's job had been really quite significant. And let me explain a little more. So those of you who are familiar with the UK-based health system know that the primary role of medical secretaries over the years has been the coordination with the patient and the production of the patient letters and communications that record what's happened to the patient is sent to the general practitioner, the GP or the primary care physician, and also to the patient and their family. So for many years, the tools of the medical secretaries have been obviously the computer, but also audio typing and a foot pedal. So the individual that I was talking to described that her role had changed really very significantly. She was no longer audio typing at all, but the EPR was auto-generating the letter. The letter needed to be checked because we needed to be sure we were sending it to the right patient and to the patient's appropriate GP. But there was very little editing that needed to be done to the letter itself. So the time taken to generate a letter had really significantly reduced, and that email, instead of the letter was now emailed instead of being printed and put in an envelope to be put in the post. So these are very, very simple changes at one level, but for an individual, they mapped out to be a very significant change in role. And they also provided opportunities for that individual to do something different, to really focus on helping a larger group of patients navigate through the healthcare system and ensure that they were seen within the appropriate timescales. Now, mapping out the workflows. One of the implications of mapping out workflows is that you can really start to see how small changes, as it may appear from a technology point of view, i.e. the auto-generation of letters, actually have a really big impact on the roles of individuals and of teams within hospitals. So that's an example of how understanding the workflows and their wider implication can help you plan for and transform the way that care is delivered and people experience their job roles.
Thanks, Fran. I think one of the things that folks always discover as we're working through these workflows is they don't understand the upstream and the downstream interactions. Like, what happens before I do my job and what does somebody need from me in order to do their job? So these handoffs and this understanding and these conversations becomes very, very important. So let's talk about when do we start working on these workflows in a project. So in this slide, we've laid out it's a very high level example of the big phases of an EPR project. So your first one is just around your readiness and your visioning. Then you're defining your scope and design. And then by phase 2, you're going to get into your system and content build. And that is the time you'll start doing your workflows. So, and you're going to map your workflows to whatever it is your vision is for what you want to accomplish with this EPR. Is it, where are you trying to improve? What are pain points you're trying to eliminate? What's your greater strategy as you move forward in putting in your EPR? Do you want to be an all digital hospital? What are those big things that you want to accomplish in the near and the long term? And you want to make sure then that having that scope and that vision, you can then share that with your staff as we start to design the workflows to accomplish that task. So you'll start in phase 2, what we're calling phase 2 there, your system and content build. And you will continue this designing of the workflows up until you get into testing your system. When you get to test, now you're only refining these workflows. You want to have a pretty good idea of what the system's going to do, because these workflows are how you're going to build and actually go in and configure the system. Once you've done that, you go into testing, you see how it's working, you go back, you tweak. The important point here is that as you make changes, as you find things that didn't work in testing and you've got to make some tweaks and do some redesigns, you go in and you update the workflows. These workflows are like living, breathing documents that you will continually refine. It could even be past go live. You could get a new piece of equipment. You could discover new functionality that's coming out with your EPR and you need to redesign something. It's important that you maintain these workflows and keep them up to date. So next I want to touch on how the workflow supports content. I mentioned that you're doing your build and design and your content. So what is content? Content refers to the tools that you're going to use within the system, whether it's a flow sheet, a note, a report. It's things that you will use for doing your documentation. So for instance, some of the tools are highly dependent on the workflow. It could be something in your revenue cycle. It could be a form that your nurses use to do their head-to-toe admission and how they run through an admission. That could be strongly aligned with the workflow. There are others that are less so, and they're shared tools like your pain scales and care plans. And then on the other end of the spectrum, you could have tools that really don't depend on the workflow. You need them, but they're not highly, the order and the content of the tool is not determined by the workflow, something like a discharge summary. Types of workflows. Okay, so we have 3 major categories of workflows for the purpose of this discussion. We talk about broad workflows. These are workflows that span the continuum. They're things that we want to make sure are standard in all areas. They're going to be shared workflows. These could be your big workflows, like how you move your patient through a system, how you admit them, how you transfer them from unit to unit, different levels of care, and then how you discharge them. It also could be things like your medication administration and allergy entry. This is where you start. You start with these big workflows that impact the most people. And then you'll start to work down to do more of your department-focused workflows. These could be workflows that are very specific to an area, like in the theaters or in the A&E. How do you get your chest evaluations or your pain evaluations done? And once those are done, when you're finishing up, you're going to get to very specific workflows that are either highly specific to a role or highly specific to an area. What's important to remember is all of these workflows are going to need to link together like different pieces in a puzzle to tell a story. So on the next slide, we took an ambulatory visit, and I'm looking at it in more of a story form. So this is telling the story of how a patient entered the system, scheduled their appointment, did their check-in, were roomed, examined, how there were orders placed, and review of those orders and billing, and how these different pieces all came together. These are many, many different workflows to create the overall patient experience and clinician experience. So now that I hope I have reiterated over and over again that workflows are very important and they're foundational to your system, let's take a deeper dive and look at some of the tools and the real art to designing these workflows to support your system build, your testing, your training, and how they'll impact every area of your project. So I'm going to turn it over to my colleague, Cindy. Take it away.
Great, thank you, Denise. Denise just talked you through some workflow basics, but in this section, we'll cover how you can approach the design of these workflows. The workflow design process can be an opportunity to not only implement your technical system, but can also provide opportunities to transform the way your organizations deliver care. To do this, though, you must be intentional with your design. Understanding your organization's short, mid, and long-term strategy, both from an operational and technical standpoint, is one of the keys to designing with intent. When beginning workflow design, you'll want to take inventory of what's important. What might be important from a technology perspective? For example, is your hospital looking for increased interoperability with other hospitals? Are you looking for a way to improve the patient experience? By intentionally using strategy as a grounding principle, workflow design can and will serve as a vehicle for these types of transformative objectives. Leveraging your project governance model, bringing all the right folks to the table, and creating systemness are other design with intent principles. Let's take a look at each one of these in more detail. We'll start with guided by strategy. Every organization has different strategic goals they hope to achieve with this new technology. There is always a business case for your implementation, but there are other outcomes outside of that cost savings that answer the why do we do this question. And many of these reasons inform the way your teams will ultimately design their workflows. When designing workflows, many of our clients align on these strategic goals. Often our clients will use their EPR implementation to improve metrics. Increasing patient safety, one of these common strategic goals, is a metric that we see often incorporated into workflow design. For example, to do this, some organizations implement common tools and alerts in their EPRs that help clinicians make better care decisions that will ultimately promote that patient safety metric. Workflow design informs who will receive these tools and alerts, and when or where is the most practical and logical place in a clinician's workflow to present the tool. Improving the patient experience is another common organizational goal we see reflected in workflow design. Many organizations implementing a new EPR today will include opportunities for the patient to experience your organization in different and new ways. A good example of this is the creation of a patient portal, which many of you may go live with when you switch over to your new EPR. With this portal, your patients can manage their own care, through appointment scheduling, clinician messaging, viewing different test results, and designing workflows for each of these functions creates a seamless and improved patient experience. Workflow design can also facilitate improved data collection. It can help you optimize your clinician's efficiency, and it can help you streamline your content. Once you have a good understanding of the strategic goals that you'll use to underpin your design, you're ready to set your parameters. Creating some guardrails to support your workflow design program helps your project team keep a holistic, bigger picture in mind and minimizes that swirl we sometimes see when parameters are not clearly defined. One key parameter is determining the metrics you will use to measure outcomes. By determining your quality and safety metrics you hope to achieve operationally, you're establishing that North Star or target for your workflow design teams. Establishing a clear vision and underpinning your workflow design with leading practices are other examples of design parameters that will help guide the way. This is a typical EPR governance structure, and I know some of you may have seen this if you were listening in on the last webinar, but today we'll look at it through the lens of workflow design. On the previous slide, we talked through the types of design parameters your organization will put in place. These were those guardrails that we just spoke about. Establishing these workflow parameters are some of the very first key decisions your governance structure will make. You'll leverage all levels of your governance structure during the planning and design phases of your workflow program. You'll use your executive team to establish the design vision, You'll use your project team and your project leaders to help determine that ultimate workflow scope and define some of the key metrics. But ultimately, most workflow design, most of the process happens at that ground floor between your project team, so those are your IT folks, your vendor, and then also your operational subject matter experts. And those are the folks that obviously know how they do their job every day, and they're critical to designing workflows. And I think Denise mentioned this, but workflow design is iterative. Your implementation will change over time. There might be new third parties that you'll use. And so you can expect to leverage this governance model for workflow decisions throughout the duration of the project. Let's move on to our third design with intent pillar, bringing all the right people to the table. The most common concern we hear from folks around workflow development, and we often hear this at Go Live, is who made that decision? Who was involved with this decision? Who said this is true? When workflow design engages all the right people, you can expect your system build to support the work people do, and you can expect better workflow adoption by your end users. Good design is based on the overlapping skill set and knowledge base of three main groups: IT, so that's your project team, your vendor, and your subject matter experts. While your IT team will ultimately drive this process, workflow design is a team sport. Everyone has a position to play. Operational involvement in design ensures your IT team can accurately map these future state workflows to capture the right operational steps. Only they know what they do at work every day, and it's critical that operations is at the table. Vendor involvement in workflow design helps your IT team, who may not yet be mature in understanding the system that you choose, include all the right technology steps and helps connect the dots when workflows are more tricky or are integrated across applications or modules. The vendor is also able to bring the "what did other customers do" lens, which sometimes helps new customers make workflow decisions. While it may be tempting to cut corners when the timeline is tight, engaging all the right people early and often is essential to the success of your workflow design program. And then ultimately the adoption of the system. If the folks who use the system are not involved in creating the workflows, there'll be lower adoption and you run the risk of some of your system build being incorrect. So we can't really overstate enough how important it is to have operations at the table for workflow design. The last design with intent principle is creating systemness, and Denise spoke quite a bit about this, and Fran did too, in their example of standardizing workflows. But oftentimes, one of the benefits of moving to an EPR is the opportunity to standardize in areas you haven't before. Making the decision to standardize things like roles, content, and workflows will create systemness. And systemness refers to providing one consistent experience for clinicians, staff, and patients. When you standardize things like roles and processes and content, your EPR facilitates systemness through familiar and consistent experiences for patients and staff. Systemness can improve patient satisfaction and can also improve clinician efficiency. An example of the concept of systemness would be the ability for your nurses to seamlessly provide care in other areas similar to their own because workflows are the same. You've standardized those workflows, so common workflows like medication administration or an admission workflow, even a discharge workflow, are the same regardless of where those nurses may practice in the hospital. Another lens to this example is the consistent experience for the patient receiving that care in the hospital by those same nurses. When a workflow is standard, care is predictable and consistent. Clinicians perform similarly to each other. The patient feels safer and more satisfied with their care. When the care is predictable, consistent, and seamless, patients, clinicians, and staff can focus on what is really important: delivering and receiving healthcare. Our experience is workflow design is improved through the use of standard tools, and I think Denise alluded to this earlier, but we have found that by using a standard set of tools, you can effectively manage your workflow development program through the course of the implementation. There are a number of tools that Deloitte has in our toolkit, and a number of tools that we would recommend for workflow development, including things like trackers, key decision templates, etc. But one I just want to highlight here is around workflow scope. And as discussed earlier when we covered governance, determining that workflow scope will be foundational to the rest of your workflow design program. Your vendor brings that starter set of workflows, the point and click workflows, but that's usually not enough to cover the breadth and depth of the services you provide, and also probably won't give a really unique lens to the different types of roles you have in your organization and the differences between you and another standard customer. So to address this gap, we have a workflow design accelerator. It's called Industry Print. And what Industry Print really is a highly curated inventory of leading practice workflow diagrams that will cover the full spectrum of your operational processes and establishes the groundwork for that customizable, iterative, collaborative future state design. You can actually do live modeling in the tool. So when you're having your workflow design sessions, you can get groups together and you can kind of move those boxes around that Denise was showing you earlier. Other tools, like I said before, that track decisions and then workflow development progress are also recommended. Now I'll hand this over to Dr. Snyder, who will talk you through some lessons learned and some leading practices.
Thank you, Cindy. Denise has defined workflows and discussed their importance, and Cindy has reviewed workflow design and the tools that can be used to manage the workflow design process. Now, let's talk about how we can use workflows to transform business processes and patient care in order to achieve your digital strategy. The workflows that your vendor may supply at best represent an amalgam of the processes and goals of numerous other organizations. As a first step in achieving your goals, your governance should design a digital strategy that encapsulates the changes and accomplishments that you envision with your EPR implementation. This strategy should be described in your guiding principles, which should be well documented and especially well communicated throughout your organization. The work groups designing your workflows can then use these guiding principles to identify the points within the workflows where specific actions can be inserted in order to achieve your guiding principles. I see it as evidence of success when a frontline worker interjects in a meeting that an action in a proposed workflow is inconsistent with an organization's guiding principles and suggests a change that is more in keeping with those guiding principles. Let's look at how this can occur. Here we see a simplified version of a typical vendor workflow for patient placement. It recommends that the individual who does patient placement takes vital signs, records allergies, and then leaves the room for the clinician to come in and see the patient. Let's say that your organization has decided that improving preventive care, for example, ensuring that women have routine mammograms and children receive their immunizations on schedule, is a strategic goal for your organization. In this case, we might want to modify the workflow and add a step where that staff member reviews a report in the EPR that identifies preventive care that is due or overdue for that patient and tees up orders for these services for the clinician to sign. This is a relatively simple change in the workflow that, when repeated over thousands of patient care encounters, can significantly improve the preventive care that your patients receive. To ensure that these workflows are fully adopted, there are several challenges that must be overcome. First, you must ensure that your trust's policies, procedures, and role definitions support your new workflows. We recommend a series of meetings called Change Impact Analysis. In a change impact analysis, most of the participants should be individuals who did not participate in the workflow design. the group is told that they are not there to redesign the workflows that were initially designed. Instead, they're asked to identify changes that need to be made to policies, to role definitions, or other desktop procedures that enable and allow the organization to benefit from the adoption of the new workflows. Fran gave us a great example of how roles may be revised as a result of EPR implementation. As another example, in the US, it was standard for 2 nurses to verify that the serial number on a unit of blood to be transfused matched the serial number on the documentation from the blood bank. At a recent implementation, a nurse noted that in the new EPR workflow, the EPR received the serial number from the blood bank software, and when the nurse scanned the information from the unit of blood into the EPR, the software verified that the numbers matched. She questioned whether there was a need for 2 nurses to repeat the step, and the organization agreed and decided that this now redundant step could be eliminated, removing the need to interrupt the second nurse, as well as saving time. As workflows fall into place, we need to communicate them broadly. What is changing? What is staying the same? Multiple methods of communication should be used: emails with focused messages, in-person demonstrations, and short narrated video clips. As healthcare teams begin to think about how they will do their work, questions about the degree of variability that is permissible will surface. The end result of the workflow almost always needs to be consistent. They are grounded in standards of practice, business needs, or your organization's guiding principles. However, I found that, especially in the ambulatory setting where teams work together consistently, there are sometimes good reasons for minor variations. One example, the standard for patient placement should include recording allergies, and that's appropriate in most clinics. But in a recent organization, the immunology clinic asked and was allowed to vary because the clinician was going to take a detailed allergy history during the visit and felt that it was redundant for another staff member to take a less granular allergy history. Finally, we need to ensure that the members of the team are able not just to perform their roles, but to work together to provide a pleasing and seamless experience for the patient. I would liken this to a symphony orchestra. Imagine that an orchestra prepared for a concert the same way that some organizations prepare for an EPR implementation. Imagine that the violins learned and practiced their parts, and the trumpets separately learned and practiced their parts, and so on. And the orchestra never practiced the symphony together until the day of the concert. Anyone want to go to that concert? Yeah, me neither. Just as the orchestra needs to practice together before the concert, the members of the healthcare team need to come together and understand their parts, and especially the handoffs of care from one role to the next that will allow the patient to have a harmonious care experience. Now, we're nearing the end of our presentation. The next step in the workflow calls for me to stop, ask Fran to rejoin us, and address your questions.
Thank you, Mark. A seamless and well-practiced handoff in the workflow there. So I hope you found that interesting and a great explanation of how workflows are essential to transformation enabled by technology, and that they can be embedded throughout the process of an electronic patient record implementation. So we have some questions coming in. So a question from Ahmed, thank you very much. So Denise, you may want to take this one. How do you ensure you involve the correct people and teams to identify for specific workflows?
That's a great question. And Ahmed, it's nice to hear from you. Typically what we do up front is we don't select people just based on individual workflows to participate in these discussions. We look for general characteristics among caregivers. So you'll want to select people who have worked with the organization for a while, who understand all of the hidden ways of getting things done. They're respected in the organization. Like, people will listen to their opinions. They're out of the box thinkers. They have the ability to see the big picture. You want to stack your teams with those types of people. Though I often recommend we also get in a couple of those naysayers, and people where nothing is ever right, because it's almost better to have them at the table and bringing them along on the journey, rather than having them kind of poke holes from the outside. Now, there could be a very specific workflow where what I just described, those general characteristics, the way we're building our workflow teams to look at the workflows doesn't work, because they only know one system. They're very highly focused, say, in the lab. Then in that case, for that workflow, you would just want to select someone who has a broad understanding in that care area and bring them in for that discussion. I hope that made sense. If there's a follow-up question, let me know.
Thanks, Denise. Mark, would you like to add on your experience of which physicians to include in this type of activity?
Thank you, Fran. And first of all, I'll say that Denise gave an excellent summary of the type of people that you want to include, especially including some naysayers. And there are two types of naysayers. There are the type who are opposed to any change. And then there are also the type who are really honestly questioning and want to ensure that the care of the patients can be delivered safely, effectively, and efficiently. And that latter group is especially the type of naysayer that you want to include on your workflow design teams and in your EPR implementation. The other thing that you want to include are those physicians who are the thought leaders in their practices. So you want to ensure that your design teams include the people who are well respected, so that when the question that Cindy brought to the fore is asked, who made that decision, you can point to the thought leaders in the various specialties in the organization and add the legitimacy of those people as the decision makers to the decisions that have been made. Thanks.
Thanks, Mark. That's really helpful. I've got another question here now about metrics. So one of the things that we mentioned was that metrics can be inbuilt, as it were, into workflows. And a question from a colleague in the NHS as to what are the typical safety metrics? You mentioned preventative healthcare, Mark, in one of your questions. What are the typical safety metrics that you see as the baseline set of transformatory patient safety focused measures that could be implemented?
So among the typical safety measures are, for example, whether medication reconciliation has occurred at both admission and discharge. We find that especially discharge from the hospital is one of the most serious opportunities for untoward events to occur. So ensuring that that handoff occurs properly and embedding into that both the medication reconciliation and also the listing of outstanding tests that still need to be checked by the next recipient of the patient's care are really important things. Other things that we look at, for example, are patient drug interactions and looking to see whether the alerts that indicate to a provider that serious drug-drug interactions are occurring or could be occurring are actually followed. So those are a couple of examples. There are a multitude of safety implications that can be built into the medical record.
Thank you, Mark. And I know from working with hospitals during the COVID outbreak that there have been a number of different safety metrics that can be put in place around COVID treatment as well. So I think what that demonstrates is the ability for the EPR, if it's got well-documented workflows, to pivot and adjust if there's a new situation such as the one we've all been dealing with over the last year. We have another question here from Stephen from the NHS. So many EPR vendors offer a one-off chance to get workflows right pre-go live, which is in stark contrast to most of the views of digital innovation, which is a move fast, fail fast mentality. What's your advice for getting the best out of your EPR supplier and keeping your people engaged in the transformation process as opposed to digitization only? So great question there. Cindy, do you have any reflections on that?
Sure. I think I would say that because this workflow development is iterative, you're going to start out with your vendor with a small set of workflows, but it'll ultimately be the folks in your organization that will decide on that full scope. So they'll be engaged from the very beginning. So you'll have to push or want to push that vendor to say, like, let's move away from those 30 workflows that you gave me. And I think we have a couple hundred that are actually applicable to our organization. And getting your folks on board, getting those proponents of this workflow development process will definitely keep them engaged. I mean, quite honestly, an implementation is usually takes quite a bit of time, and design takes quite a bit of time. And I think selling people on the value and the importance of staying involved will really pay off in the end.
Can I add one other thing? I think I echo the concern of whoever brought up that question. We typically do hear from some vendors, let's just get the system in, get our people using it, and we'll work out the kinks as we move along. And I think collectively we all agree that is not the right approach. You have this one opportunity where you have all eyes of the organization and the energy and the resources to get this system in. So don't waste this opportunity. Don't rush it. Take the time, get your workflows right, talk things through.
Mark, anything to add?
I again agree with my colleagues here. The one thing I will say, though, is that, and I mentioned during my introduction, optimization continues to occur. So you want to make sure that you get the important things right. And unlike many other endeavors, healthcare is not one where there is tolerance for error. So you want to make sure that your workflows are right at go live. But as your organization understands the EPR, as there are additions, as there are optimizations that your vendor will supply, you'll see opportunities to continue to improve the workflows, continue to improve how you engage patients. And so I would not look at it as a once and done thing, but rather as an opportunity for really continuous quality improvement.
Mark, thank you. I would agree with that. Just reflecting on my experience in large scale implementations, I'd say one of the things you can do really intentionally, to use Cindy's word at the beginning, is to look at your quality strategy, particularly, and any pain points or issues, or if you're, for example, implementing a new physical facility or a new model of care, and look intentionally at what you want to change and engage your vendor and say, we have these very specific challenges within our health system, or these concerns around safety, or these opportunities to improve. And it is our collective responsibility, the trust, the vendor, the implementation team, to ensure that we are designing workflows intentionally to address these issues. And I think that's often a conversation, and I can say in my experience, there's conversations I haven't had and should have had, that really engages the vendor too in some of the efforts that the organization wants to make, and they will have experience. Many of these vendors obviously have hundreds, if not thousands, of implementations globally, and somewhere in one of those organizations there'll be really great experience in addressing that operational clinical challenge that you want to progress. So I would definitely say engage the vendor as well, and have the confidence that the methodology that the vendor brings is a great starting point, but it doesn't have to be the end point. Okay, so we have another question here about research. So I come from a research orientated institution. What advice can you give me on the engagement of the research community in the development of workflows? So I just wondered, Mark, if you have experience in working in some of these very research-intensive organizations.
I do, and I think that researchers tend to be fairly conservative. They tend to very much want to see what happens, and so I think that your initial goals, number one. In oncology, there are often a number of experimental protocols that are maybe common across multiple organizations that your vendor will provide you opportunities to add into your implementation. And similarly, that you may want to build into your implementation. The other thing is that there are certain common workflows, such as how information that is specifically from research visits will flow to the research coordinators and to the investigators, and those things you will want to design. There are other things that do very much follow the advice that I gave, that the EPR is a living, breathing thing, and that as the researchers see the EPR often in their own practices, they will see additional opportunities both to build workflows into the EPR and also to mine the EPR for information that may be useful in optimizing care within your organization.
Great point, Mark, because I think as we said in one of the design with intent principles that Cindy articulated was, we're creating, by dint of having these really carefully curated workflows, a set of data that is very well understood and clearly structured and provides a great opportunity for quality improvement and research going forward. So another question here about patients and patient portals. So we're at the beginning of our EPR implementation journey, and we would very much like to involve patients in portal design. Do you have experience of that? And if so, what would you recommend? Cindy?
Yeah, I think that's a great idea, because ultimately the patient and the clinician have equal parts in those workflows. It's really the connecting point. That portal is the connecting point in care between the patient and the clinician. And what I've seen done in other organizations that are designing the portal is they'll often engage the patient experience team that organizations have, where they reach out to patients, survey patients, talk about that, talk them through, this is what we like to do, what do you think you would like to see? And then I've also seen patients get engaged later in the process, where they're brought in and we say to them, okay, we want you to log in, want you to go through the portal. Do these workflows make sense to you? Is it intuitive? So I think there's definitely that opportunity to engage patients throughout the course of that design.
Great, thanks, Cindy. Denise, got any experience in this area?
I think my experience and my answer would have mirrored what Cindy just shared. Patient experience, having people touch and feel the system and giving you feedback on, how easy it is to navigate and how intuitive it is. So very important. I agree.
Great, thank you very much. So we have another question here about effort. So workflow design, from what you've said today, needs to be at a very granular level. Can you give us a sense of what level of effort and what kind of program team you need to put around a granular workflow design process? So Denise, do you want to start there?
Sure. I don't want to underestimate the amount of effort. You know, they can be very intense. What you're going to need, and what we would typically use, if we're not on the if Deloitte isn't there to help support this work would be led by the project team. So the folks that are doing the build in your system are usually helping out with the workflows, along with some of the support from your training team. Because as you move downstream and these workflows become more mature, the training team is the one who's going to be utilizing them. So upfront, they would be your work group leaders, and they'd also be helping you to do the documentation of the workflow, because that's the big work. You know, you bring the group together, you brainstorm the ideas, you map things out. Somebody needs to get those into the Visio format or into the industry print format. And that is going to be your build team or your trainers, as I said. It also, you might, if you have the bandwidth, bring in some very specific folks to be the analysts to do the documentation and the scribing on those workflows. That's another option.
Thanks very much. And just to add to that, Denise, how long do you think it would take? I mean, what if you're making a project plan, what sort of allocation of time do you think design requires for a single hospital, say?
Well, it's going to go hand in hand with the timeline for your design and build of the EPR. So the design and build phase of your EPR, not into the test. So up until testing, that's how long you really have. And for a usual implementation, that could be 5-6 months.
Okay, great.
And
well,
you will also have multiple groups running at once, Fran. This is not just a linear activity. You have many things happening in parallel, many groups meeting and doing their design. I hope that helps.
Absolutely, thank you very much. And I think from a resource planning perspective, it's also important to think about the impact on the clinical teams. They'll need time out of their schedules when they're not rostered or running clinics, etc. But it is time really, really well spent in terms of intentionally transforming your organization. So thank you to everyone who's asked a question and to the wonderful panel who's answered them all. Really appreciate those insights. We'll now move to at the end of the webinar with just 2 more pieces of information for you. I'll hand now to Mark.
Great, thank you, Fran, and thank you to my colleagues for doing a great job in terms of helping to demystify a very complex topic. Hopefully we've been good resources for you today and will continue to be so in the future. I also want to take a moment just to point you in the direction of the Deloitte Center for Health Solutions. This is an area where we spend a good amount of time and investment on research and very current topics, many of them which will be very important to you in your particular market. So what I would encourage is that we have one in the US as well as one in London, but some of the articles here you'll see will be very relevant to you, particularly around performance improvement and many of the things you'll be taking on in the future as you go forward. In your follow-up information, you will actually have links to this, and we look forward to actually providing you more information in the future on this. And Fran, I know that we have folks typically from all parts of the world access the centers, and I would encourage anybody in the 12 countries that are a part of this seminar today to absolutely visit it. So with that, let Fran conclude. Thank you.
Thank you, Mark. So I hope you've enjoyed the webinar today. We've certainly enjoyed preparing for today and also delivering the webinar this afternoon. As you can see, it's a topic that we're really passionate about because we do fundamentally believe that technology has the ability to transform the way patients and staff experience healthcare. And on that related topic, change requires adoption and it has impact. And what we'd like to talk to you about in the next webinar on Thursday, the 29th of April is that topic of change management and communication, of how we engage with large groups of staff in order to support them to adopt and feel confident in practicing with electronic patient records. So please do sign up for the webinar on the 29th between 4 and 5 British Summer Time, and we would love to see you then at the end of the month. So thank you all very much for joining, and I hope you have a very pleasant rest of day. Thank you.